Welcome to the deep dive. Today we're really zeroing in on something vital for patients with end-stage renal disease, hemodialysis access. The need is definitely growing, with aging population, rising diabetes rates, and maybe surprisingly, access failures cost billions every year.
Billions, yes.
Yeah.
It's a huge issue, and getting hemodialysis access right is just so critical. So our mission today really is to pull out the essential instructions for vascular surgeons, kind of like a focused manual, drawing directly from those key chapters in Rutherford's Vascular Surgery, Section 27, specifically chapters 174 to 178. They're all about this.
Exactly. We're digging into Rutherford's to give you, our listeners, the core strategies. Because it's clear, isn't it? A simple one-size-fits-all way just doesn't cut it anymore. It's all about the right access for the right patient at the right time. Needs a really tailored approach. Okay, let's break it down. Where do we start before even thinking about surgery?
It all begins with a preoperative evaluation. That really sets the stage for success or potential problems down the line. And a huge piece of that is the timing of the referral. Both the KDOQI guidelines and the Society for Vascular Surgery say refer patients when creatinine clearance dips below 25 millimomen.
25. Okay.
Ideally, you want that referral happening more than 6 months before you actually expect dialysis to start.
6 months? Wow, that seems as a lot of lead time. Why is that so critical, practically speaking?
Well, it gives that crucial time for autogenous accesses, using the patient's own veins to mature properly. And maybe even more importantly, it drastically cuts down the need for those central venous catheters. Studies show getting the access placed more than 4 months ahead can really lower the risk of sepsis and even death simply by avoiding those catheters as much as possible.
That makes sense. Avoid the catheter, avoid the infection risk.
Exactly. But, the tough reality is, despite these guidelines, only about maybe 25% of patients actually start dialysis with a permanent AV access in place.
Only a quarter. That really highlights a gap in care before dialysis even begins.
It really does. It's a major area we need to improve.
So, okay, the patient gets referred early, hopefully. What's the surgeon's next step? The sort of detective work in that first evaluation.
Oh, the history and the physical exam are just absolutely fundamental. You need really thorough history, asking about their dominant arm, any history of IV lines, especially central lines, and that includes things like pacemakers, defibrillators, anything implanted.
Right, those central devices are key.
Definitely. Plus, any previous access procedures, any trauma or surgery on that arm, there are other health issues. Age, diabetes, smoking history are big ones, and of course, what medications they're currently taking.
That's a lot to cover just in the history. And the physical exam, I assume it's more than just checking a pulse.
Oh, absolutely. You've got to carefully check the brachial, radial, ulnar arteries. Are they easily compressible? Are the pulses equal in both arms? The Allen test is non-negotiable. You need to confirm that palmar arch is patent, ensuring good collateral flow to the hand.
Critical for preventing hand problems later.
Exactly. And then a really close look at the superficial veins. How well do they distend? Any breaks or blockages when you put a tourniquet on? And you're looking for clues like prominent collateral veins on the chest or arm swelling. Those can hint at potential central venous stenosis.
Central venous stenosis. Sounds like a big potential roadblock. Okay, moving on to the broader medical picture. Clearly, the patient's overall health plays a huge role. Let's start with age.
Age is definitely a factor. There was a meta-analysis that showed higher failure rates for those radial cephalic fistulas, the standard forearm ones in older folks. But interestingly, the brachial cephalic fistulas, the ones higher up in the arm, actually had better patency in that group.
So maybe think upper arm first in older patients.
Yeah, it suggests we should seriously consider upper arm options, either autogenous or even prosthetic, rather than just automatically going for the distal forearm in elderly patients. It's about anticipating potential issues.
Yeah. Makes sense. Adapting the plan based on age-related changes. What about diabetes? That's obviously a huge factor in kidney disease itself.
Oh, diabetes has a clear negative impact on access patency. You get more arterial calcification, more atherosclerosis, and that ups the risk for both clotting, thrombosis, and also arterial steal, where blood flow gets pulled away from the hand.
Seal syndrome, yeah.
So the general recommendation for diabetic patients is to use the most distal arterial inflow possible. Put the connection as far down the arm as you reasonably can to minimize that risk of steal.
Right. Minimize steal to avoid those really nasty hand ischemia issues we'll probably touch on later. And smoking, I guess that's another big one you can actually modify.
Huge. The evidence is really clear. Smoking significantly boosts both early and late access failure rates. So getting patients into tobacco cessation programs is just, well, Essential before creating any access. Strongly recommended.
And medications. The outline hinted that's a bit murky.
Yeah, it's tricky. A lot of the data is observational, and honestly, the results are kind of conflicting. The DOPPS study suggested some potential links. Maybe ACE inhibitors help secondary patency for autogenous fistulas, maybe calcium channel blockers help primary patency for grafts, aspirin for secondary graft patency.
Yet then warfarin might hurt graft patency.
Exactly. And then USRDS data hinted antiplatelets might decrease patency overall. Some studies even suggest ARBs might help, maybe with antiplatelets. But the bottom line, there's just no solid consensus right now on routinely using specific drugs to boost access patency.
So more research needed there. It really comes back to individualizing care.
Absolutely. It reinforces that need for a personalized approach.
Okay, let's shift to assessing the vessels themselves. The arteries first, how do you make sure there's enough inflow for the access?
Well, if the clinical exam raises flags, weak or absent pulses, a weird Allen test result, maybe different blood pressures in the arms, then you move to non-invasive tests. Segmental pressures, duplex ultrasound, maybe pulse volume recordings.
What's the ideal picture you're looking for?
Ideally, no significant pressure difference between the arms, an artery diameter of at least 2.0 millimeters, and definitely a patent palmar arch confirmed by that Allen test. If those tests show problems, then an arteriogram using contrast dye might be needed to really see the anatomy and maybe even treat any blockages limiting inflow.
But the contrast risk, especially before dialysis starts.
That's the balance, exactly. You have to weigh the risk of contrast nephropathy against needing that access ready before dialysis starts. If you do need contrast, you absolutely use renal protective measures.
A careful balancing act. Okay, inflow checked. Just as vital is the outflow, the venous side. How do you map that out?
Right. If you can't easily see or feel good superficial veins, or if something seems off on the exam, then a superficial venous duplex ultrasound mapping is the next step. It's essential.
What are you measuring there?
Key things are the vein's diameter, how well it distends or stretches under pressure, and its continuity is that it open all the way, no major blockages or narrow spots. There's some debate on the minimum diameter needed for the forearm. Some say 2.0 millimeter, some 2.5, some even 3.0 millimeter. And those different cutoffs do correlate with different maturation and success rates. So bigger is generally better, but there's some flexibility, pretty much. And you always have to be suspicious of central venous stenosis, especially if you see those collateral veins on the chest, arm swelling, a big difference in arm size, or if the patient has a history of central lines or lots of previous accesses on that side.
What do you do if you suspect central stenosis?
Then you do a deep venous duplex ultrasound first, looking at the bigger veins closer to the chest. If that's abnormal or unclear, then a venogram might be necessary to get the full picture. And again, same careful consideration about contrast risks in pre-dialysis patients, using protective measures if needed.
So you build this detailed vascular map before even picking up a scalpel. Okay, that leads us right into the surgery itself, creating the access. It's clearly not just plumbing, right? It's skill, it's anatomy.
It absolutely is. And it always comes back to that mantra. Right access, right patient, right time, thinking about their whole ESKD life plan. We generally focus on the upper extremity first, so let's start with the forearm, often the first place we look.
Forearm access, usually the cephalic vein or the basilic vein, right?
That's right. For an autogenous access using their own vein, the cephalic is usually preferred. It's more superficial, more lateral, so generally less digging around is needed. The artery feeding it, the inflow, can come from a few places. The posterior branch of the radial artery down in the snuff box.
The snuff box fistula, yeah.
Or the distal or proximal radial artery, that's your classic radiocephalic. The breccia fistula. You can use the ulnar artery, but it's less common as a first choice. And a key principle here is always try to place that connection, the anastomosis, as far distally as possible. Save the upstream real estate for later if needed.
Preserve options. What if the cephalic vein isn't ideal right at the wrist? Too deep, maybe?
Good question. If it's too deep or not close enough to the radial artery, you might do a radial cephalic forearm transposition. Basically, you mobilize the vein and tunnel it more superficially. Or if the radial and ulnar arteries themselves aren't great, you can even do a looped transposition using the brachial or proximal radial artery as inflow.
A loop, so you create a longer segment for needling.
Right.
Okay, what about the basilic vein in the forearm?
The basilic is the go-to alternative if the cephalic isn't suitable. But because it's deeper and more medial towards the inside of the arm, it always needs a transposition to bring it up to where it can be cannulated.
Always needs moving.
Always. The inflow usually comes from the proximal radial or the brachial artery. Again, placed distally if possible to reduce steal risk. So you might have a proximal radial basilic transposition or a brachial basilic transposition. And just like with the cephalic, you can do looped transpositions to proximal radial basilic loop if the distal radial artery is poor, or a brachial basilic loop if both radial and ulnar are out, but the brachial is okay.
Lots of autogenous options tailored to the anatomy. And then, of course, there are prosthetic grafts in the forearm.
Right. If autogenous isn't feasible, the standard prosthetic option is often a straight graft from the radial artery at the wrist up to an antecubital vein near the elbow. That's a radial antecubital straight access. Or, if you need more proximal inflow, you can do a looped graft, usually from the brachial or proximal radial artery to the antecubital vein.
Okay, that covers the forearm pretty well. Moving up the arm, what are the choices there?
Similar principles apply in the upper arm. You can use the cephalic vein, usually connecting it to the proximal radial or the brachial artery again, placing the anastomosis distally on the artery. That gives you a proximal radial cephalic or a brachial cephalic direct fistula.
And the basilic vein, again, needs transposition.
Yep, basilic in the upper arm always needs transposition because it runs deep. Inflow again from proximal radial or brachial placed distally. So proximal radial basilic or brachial basilic upper arm transpositions. And for prosthetic grafts up there, you might run a straight graft from the brachial or proximal radial artery up to the axillary vein near the shoulder, or sometimes a brachial looped graft in the upper arm itself.
It really is a whole toolbox of surgical options. Are there some general rules, some basic principles that apply no matter which type of access you're creating?
Definitely. For autogenous fistulas, after you isolate the vein, you usually cut the distal end and flush it gently with heparinized saline. That lets you check its size, see how far it goes, and spot any big side branches. Handling tissues gently, meticulous hemostasis stopping bleeding, that's crucial. The anastomosis itself is typically done with fine, non-absorbable stitches.
And those side branches.
Right. For fistulas that aren't transposed, you often need to tie off large side branches, usually through little stab incisions after the main connection is made. That forces more blood flow down the main channel, which is really important for helping it mature and get big enough for dialysis.
Makes sense, directing the flow. We talked about transposition. Is it better to do it all in one go or in two stages?
That's a really important decision, the one-stage versus two-stage transposition.
Okay.
One stage has the obvious benefit, one operation. But if that transposed vein then fails to mature, the patient went through a big dissection for nothing, and they might be understandably hesitant about trying again.
Right, kind of burns a bridge.
Could feel like that. The two-stage approach starts with just the direct artery-to-vein connection. Let that mature for, say, 4 to 6 weeks. If it develops well, then you do the second operation to transpose it superficially.
Benefits of two-stage.
Well, you're more sure the vein is going to work before doing the bigger transposition part, and sometimes the dissection is a bit easier once the vein has matured some. Drawbacks are obviously 2 surgeries, 2 anesthetics, slightly higher overall surgical risk. Generally, we lean towards two-stage, mostly for smaller veins, maybe less than 4 millimeters, that have a higher chance of not maturing anyway.
Okay, reserve it for the more borderline veins. What about the specifics for putting in a prosthetic graft?
With a prosthetic graft, usually 6 millimeter PPFE, the cut in the artery, the arteriotomy, isn't really limited by the graft size itself. Before sewing, you flush the artery both ways with heparinized saline helps prevent clots forming right away. Then the sewing, the anastomosis, both artery and vein side, are usually done with a fine monofilament suture, like 6-0 or 7-0, in a continuous stitch.
Got it. And you mentioned early cannulation grafts earlier. What's special about those?
Yeah, those have a special 3-layer design, sort of an inner layer, a reinforced middle, and an outer layer. The idea is it helps minimize bleeding from the suture lines and the needle sticks later. So theoretically, you can cannulate them much sooner, maybe 24 to 72 hours after surgery.
To get rid of the temporary catheter faster.
That's the goal. Potentially avoid or remove the temporary catheter quickly. Some places use them, report faster cannulation times.
Yeah.
But honestly, the evidence isn't overwhelming that they have better long-term patency than standard grafts, so it often boils down to surgeon preference in the specific situation.
Okay. And lastly, the HeroGraft hemodialysis reliable outflow. Sounds like a specialized fix.
It really is. The HeroGraft is for patients with serious blockages in their central veins, subclavian and nominate, that you can't fix with surgery or balloon stents. It has 2 parts. A venous outflow piece, basically a silicone tube that gets tunneled into the central vein past the blockage, kind of like a dialysis catheter.
Oh.
And an arterial graft part, usually 6 millimeter EPTFE, that gets tunneled under the skin in the arm and sewn to an artery, like a normal graft. But, and this is important, HeroGrafts tend to have lower success rates and more complications than standard accesses.
So not a first choice.
Definitely not. It's really reserved as a last resort for those tough central vein occlusion cases when the only other options might be temporary catheters long-term or maybe trying access in the leg.
Wow, okay. A truly wide range of surgical tools. But the job isn't done when the patient leaves the OR, right? Post-op and long-term care are just as vital.
Absolutely critical. Postoperative follow-up is key. Autogenous fistulas, remember, need time typically around 12 weeks to mature properly for dialysis. Prosthetic grafts are much faster, usually ready in about 2 weeks.
What if they don't mature on schedule?
Then you need to investigate. Duplex ultrasound, maybe a venogram, to figure out why. Often you can salvage these failing accesses with secondary procedures, either open surgery like vein patches or bypasses, or endovascular things like balloon angioplasty. Studies clearly show that catching maturation failure early and intervening makes a big difference in actually getting a working fistula.
And what about this BAM, balloon-assisted maturation?
Ah, yes. BAM involves doing serial balloon angioplasties on small veins to try and force them to dilate enough. It can work, sometimes. But there are downsides. It might make the fistula behave more like a prosthetic graft in terms of needing frequent reinterventions. And there are definite cost implications, too. It's a bit controversial.
Okay. So once it is mature and working, how do you monitor it long-term?
Well, the thinking has shifted a bit there. It used to be common practice to do monthly access flow measurements. But the latest KDO-QI guidelines actually say there isn't strong enough evidence to recommend routine surveillance with flow or pressure measurements or imaging if there aren't any clinical problems.
Really? So less routine testing.
Yeah, the focus now is much more on regular, careful physical examination by someone experienced and knowledgeable practitioner. The idea is don't intervene preemptively just based on a number if the access seems fine clinically. But if the physical exam does pick up something abnormal, a change in the thrill or brute, for instance, then you absolutely investigate further with a fistulogram and potentially perform secondary procedures.
Interesting shift towards clinical assessment over routine numbers. Now, unfortunately, accesses do fail sometimes despite best efforts. How do you usually find out? And what can be done?
Often the first clue comes from the dialysis unit staff. They're on the front lines. They might notice it's getting harder to cannulate, the venous pressures during treatment are creeping up, bleeding takes longer to stop after needles come out, maybe there's too much recirculation, or the machine alarms with high negative inflow pressure, suggesting poor flow coming into the circuit.
So communication with the dialysis team is key.
Absolutely essential. Then, the surgeon's physical exam adds more pieces to the puzzle.
What specific things are you looking for on exam?
You look carefully at the skin, any breakdown, swelling. Prominent collateral veins suggesting central outflow problems. You feel for the thrill should be continuous, palpable, right for the anastomosis down the outflow vein into good access. Is it too buzzy or pulsatile? That can mean outflow stenosis. Sometimes you can even feel where the thrill changes, pinpointing the stenosis.
And listening.
Listening with a stethoscope, yeah.
Yeah.
A healthy access usually has this continuous, low-pitched whoosh. A high-pitched, mainly systolic brute often means a significant narrowing. Also, if you lift the arm, a healthy fistula should collapse somewhat. If it stays distended, that's another sign of outflow blockage.
Okay, so it's a combination of reports and careful examination. When an access is clearly failing, what are the fixes?
We have that range of options again.
Oh, yeah.
Open surgery, percutaneous endovascular techniques, or often a hybrid approach mixing both. For narrowings, stenosis, open surgery might mean putting in a short bypass graft around the blockage, or doing a patching angioplasty, sewing a patch onto the narrowed bit to widen it. Both tend to work about equally well long-term.
And the percutaneous options.
That's primarily balloon angioplasty, threading a balloon catheter across the narrowing and inflating it. Sometimes a stent, a little metal scaffold, is placed to help hold the vessel open. The hybrid approach just combines these as needed for more complex problems.
What about when it clots off completely, thrombosis? Is the access finished then?
Not always. Thrombosed autogenous fistulas can be tougher to salvage because you risk damaging the veins inner lining, the endothelium, when you remove the clot. Prosthetic grafts, which actually thrombose more often, usually due to that intimal hyperplasia, thickening at the venous connection.
Right, the common failure point.
Exactly. Those are often salvageable. Grafts tolerate the mechanical clot removal, the thrombectomy, better because they don't have that delicate lining. You can even sometimes cut out a bad segment of graft and replace it. And using those early cannulation grafts sometimes comes into play here, maybe as a bridge, to avoid a central catheter while you sort out the thrombosed access.
So even a clotted access isn't necessarily game over. How do you actually get the clot out?
Open surgery involves getting the clot out quickly, usually with a balloon thromboembolectomy catheter, like a 4 French size for a standard 6 mm graft. But crucially, you must find and fix the underlying reason it clotted, usually that venous outflow stenosis, but maybe a pseudoaneurysm or poor inflow. The incision is planned based on what repair you expect to do.
And percutaneously.
Percutaneous options include mechanical thrombectomy devices like angiojet that physically break up and suck out the clot, or pharmacologic thrombolysis, dripping clot-busting drugs right into the thrombus.
Okay, we've covered creation, upkeep, and fixing failures and clots. Let's shift to other problems that aren't thrombosis, starting with bleeding.
Right. Bleeding from the axis can happen for various reasons.
Yeah.
Maybe too much heparin during dialysis, trying to use a new access too soon, infection, a pseudoaneurysm or true aneurysm developing, or rarely the access just rupturing.
How do you manage that?
First, figure out the cause. For minor bleeding, direct pressure, maybe topical agents often work. For more persistent bleeding, sometimes figure of 8 stitches or vessel loops are needed. If it's active, uncontrolled bleeding, that's a surgical emergency. Short-term fixes in acute situations might include platelet transfusion or giving DDAVP.
Infection seems like another major headache, especially with grafts.
Huge headache. It's the second leading cause of death and access loss. And yes, much more common with prosthetic grafts than fistulas. Infections get classified early versus late, culture positive or negative, where exactly it is. Staph aureus is the usual culprit, often MRSA.
What are the risk factors?
Lots of things. Repeated needling in the same spots, poor technique or hygiene, hospital stays, how long the graft's been in, older age, access in the leg, diabetes. Even the buttonhole technique has been linked to higher infection risk in some studies. Dialysis catheters, of course, have the highest infection rate overall.
How are infections diagnosed and treated?
Diagnosis is mostly clinical exam redness, drainage, maybe the graft is exposed. Imaging can help sometimes. Treatment starts with broad-spectrum antibiotics, then you narrow it down based on cultures. Fistula infections, often related to needling or hematomas, frequently clear up with just antibiotics, maybe 2-4 weeks worth.
And graft infections.
More complicated. If it's just a small, localized segment, you might be able to salvage it by cutting out just that piece. But if the infection is at the anastomosis, where the graft meets the artery or vein, that usually needs prompt, complete removal of the entire graft to avoid catastrophic bleeding. And remember, even a clotted graft can still be harboring infection.
Scary stuff. Okay, what about pseudoaneurysms and true aneurysms? You mentioned them with bleeding.
Yeah, some dilation of a fistula vein is normal, expected.
Yeah.
But if it gets really big, say over 18 millimeter or 3 times the normal matured size, we call it an aneurysm. Pseudoaneurysms are basically contained leaks, often needle sites or anastomosis. True aneurysms are outpouchings of the whole wall, often linked to downstream stenosis, repeated cannulation, or scarring.
What problems do they cause?
They can make cannulation difficult, look bad cosmetically, clot off, cause pain, bleed, or get infected. If they get big enough, the skin over them gets thin, and they can even rupture spontaneously.
How do you treat them?
Depends on where it is and how bad. If it's right after the anastomosis, maybe relocating the anastomosis is best. Small dilations might improve if you treat an associated outflow stenosis with angioplasty. You could do open repair, cut out part of the aneurysm and patch it. For diffuse bulging, maybe partial aneurysmectomy. Arterial aneurysms are rare, but might need fixing depending on size and symptoms.
Seromas, those fluid collections. What's the story there?
Seromas are collections of clear fluid near a new access, usually in the first month. Can be from lymphatic leak during surgery, old bleeding, maybe just tissue reaction. They show up as soft swelling, can make needling tricky.
What do you do about them?
You generally don't want to just stick a needle in to drain them high risk of infection, especially near a graft. If it's big enough to interfere with dialysis or threatens the skin, then surgery is needed. Often means excising the seroma sac, maybe rerouting the graft. Sometimes using things like microfibrillar collagen or fibrin glue can help it heal and maybe save the access.
Access-related hand ischemia, ARHI. That sounds serious.
It is very serious.
Yeah.
It happens when the access steals too much blood flow from the hand. Some degree of physiologic steal is normal, but ARHI is when the hand doesn't get enough blood because the collateral circulation can't compensate.
Who's at risk?
Patients with low finger pressures beforehand are at higher risk. That's why we try to avoid distal brachial artery-based accesses in high-risk folks, and maybe use tapered grafts in diabetics to limit flow a bit. Symptoms range from just cold fingers and tingling to severe pain, weakness, even tissue loss.
How do you diagnose and treat it?
A key sign is that the symptoms get better when you compress the access. Objective tests include finger pressures, PVRs, duplex scans, maybe angiography. Treatment aims to relieve the ischemia while hopefully saving the access. Options include reducing access flow like surgical banding or increasing flow to the hand distally. Procedures like RUDI, PAI, DIL aim to do that. Sometimes angioplasty of hand arteries helps. Ligation, tying off the access, is really the last resort for limb-threatening ischemia. It's a complex decision based on severity, access flow, other options.
A real balancing act. Then there's venous hypertension.
Right. That's usually from stenosis or blockage in the central vein subclavian, innominate often caused by old central lines. Causes arm swelling, pain, prominent veins on the chest shoulder, makes the access function poorly, high venous pressures, prolonged bleeding.
Diagnosis and treatment.
Diagnosis usually involves venography, maybe with IV US ultrasound inside the vein. Treatment is often angioplasty and stenting of the central vein blockage. But restenosis rates can be pretty high. Stent grafts might be better sometimes. Surgery to bypass the blockage is an option for tough cases. And again, the hero graft is a final consideration for unreconstructible central blockages.
Okay. Ischemic monomelic neuropathy, IMN. Another rare but nasty one.
But very rare, thankfully, but devastating. It's acute nerve damage in the forearm and hand due to ischemia. Comes on fast, just hours, severe pain, numbness, weakness. Treatment has to be emergent. Either ligate the access or do surgery immediately to boost blood flow to the hand. Sadly, recovery is often incomplete.
Finally, cardiopulmonary complications. How does the access affect the heart and lungs?
Well, a high-flow access significantly increases the work the heart has to do, increases cardiac output. In someone with heart problems already, that can tip them into congestive heart failure. There's also coronary seal syndrome. If a patient has had a mammary artery bypass graft, a high-flow access on the same side can literally steal blood from the heart muscle.
Wow.
Yeah. Other rare things include bits of stents embolizing to the lungs or heart, or the chronic high flow contributing to pulmonary hypertension. Treatment usually involves reducing access flow banding, ligation, maybe RUDI, or managing the underlying heart condition.
This has been just an incredibly thorough walkthrough, really distilling those essential Rutherford's chapters on hemodialysis access. It's so clear that success demands so much deep preoperative thought, skilled surgery, vigilant follow-up, and managing a whole host of potential problems.
Absolutely. If you boil down the key message from Rutherford's on this, it's that durable, successful access relies on that meticulous planning up front, tailoring the surgery to the patient, watching closely afterwards, and acting quickly and appropriately when complications pop up. It's a continuous process.
And it's definitely not something the surgeon does in isolation, is it? That collaboration, the communication with the dialysis team seems absolutely vital.
Couldn't agree more. That seamless teamwork and open communication between the surgeon, the nephrologist, the dialysis nurses, everyone involved, is paramount for getting the best outcomes and quality of life for these patients.
So while this deep dive drawing heavily on the wisdom in Rutherford's gives a great framework, it's crucial to remember this field is always changing, right? New techniques, new evidence.
Exactly. Vascular access surgery is constantly evolving. Continuous learning, adapting to new data, staying engaged with the latest research. It's essential for anyone dedicated to optimizing care for hemodialysis patients.
Well, thank you for guiding us through this incredibly detailed exploration. We really hope this has been valuable, and we encourage all of you listening to delve deeper into those Rutherford chapters and keep exploring this critical field.